My name's Uraon. I'm a domiciliary optometrist for the OutsideClinic. Today we're talking about adapting our routine to a bedbound patient. So I'm just going to pop this on you there. Generally, when I walk into the room with a bedbound patient, or even before I enter the patient's home, it's often a key safe to enter. So I'll normally pop the key code in, open the door and shout into the room to let them know that I'm there. And then I'll ask for their consent to enter the room. I normally start by introducing myself to the patient and asking for permission to lie anything on the bed. Hi, my name's Uraon. I'm going to be a domiciliary optometrist today. Is it okay if I just put my equipment on the bed?
Yeah, of course.
It's often important to angle the patient in a position that's comfortable for them, but also easy for you to do your test. So we can often use things such as pillows to prop them up slightly. Some patients may have an adaptable bed, which makes it much easier. An adaptable bed often has a remote that comes with it, so you can adapt the head position or the bed position in order to sit the patient more upright. Before I start my test, I normally clear the bed space to make sure that there's enough room for me to maneuver around. When you walk into a bedbound patient's home, or any patient's home, it's always important to adapt the lighting to that you would have in a normal testing room. So I often aim to close the curtains and use any lamps or room lights to adjust the lighting to suit. When setting up the patient room, the first thing I like to do is think about where the patient's sitting and the tasks that they have around them. When setting up the patient's chart or the test chart, we normally have that about 3 meters away to the patient. I often aim to put that on an elevated surface to make sure there's nothing obstructing the patient's view, and it makes it clear for them to look at when they're lying in their natural position. So if you just take hold of this for me and hold that up towards your chin, we normally give the patient one end of a tape measure and ask them to hold that up to the chin, and then we'll accurately measure that 3 meter distance. That's great, you can let go just there for me. If we can't get a 3 meter space, often we can ask the patient either to turn their head slightly and put the test chart somewhere that's more appropriate to allow us to have that distance, or we'll shorten the room and account for that in our test results. When doing a domiciliary eye care test for a bedbound patient, what I'll often do is sit at the end of the patient's bed when I have my conversations with them. I'll ensure that when I set up my equipment, I'm within their point of view so that I'm not going behind them, as that can make them feel uncomfortable. I often think it's important to set up the test chart at a point that's suitable for them to view without them having to put their head into a position that's uncomfortable for long periods of time. We fit the trial frame appropriately to make sure that we take accurate measurements and can record their vision as best as possible. So when doing domiciliary eye care, I often aim to dilate all patients unless there's any specific reason not to. Obviously, this is bearing in mind the patient's consented to me putting in these eye drops. So I often find it's often important to dilate just to allow you to have a really good wide view of the patient's retina. We don't have access to some of the OCT scans that we may have in everyday practice, so this allows me to be more confident in the assessment that I make of the patient's eye. So in terms of the equipment that allows us to do domiciliary eye care, all of the equipment's portable and very lightweight. It all fits into one case, so it's easy for us to use. We use a pan optic, which allows a wider field of view. We have a fundus camera, which allows us to check our fundus findings. We use an eye care tonometer. For a patient in a supine position, there's often some adaptations we need to make in order to take the pressures. One thing we can do in this position is prop more pillows behind the patient's head. If we only have one pillow, we can fold that pillow in half or put some things just behind the pillow to prop it up further. If you just lift your head up very slightly for me, that's it. I'm just going to pop this behind you. The great thing about the eye care tonometer is you can hold it at various different angles and still take recordings. That's especially important for patients that are bedbound. So in order to take the pressures on a patient lying down or in this position, we'd normally use our fingers as a rest in order to monitor the distance between the eye care tonometer and the patient's eye. So I'm just going to be resting my fingers on you there slightly. The great thing about the eye care is we don't need to instill anaesthetic before taking measurements, and it's very accurate. When considering dispensing at the end of a patient's routine, it's often important to take into account the patient's natural head position and the position that they generally are throughout the day and the tasks that they have around them. So we think about things like the distance their TV is from them, perhaps the distance they hold things when they read. I often tend to opt towards bifocals as opposed to varifocals, as these work better for the patient's head position. We also consider things like 2 separate pairs of glasses for ease of use, but we'll have these discussions with our patients and allow them to make an informed decision. The lighting itself is its own visual aid, so we often advise patients on lighting around their room to help them with their visual tasks. Things that are great are desk lamps that have windy necks, so we can point them towards the things that we're looking at, or flexible arms in order to position them into positions that help us with our tasks.